Hello and welcome to the Wizard and the Priestess. I'm your host, Matt. This week, exploring one of the most common issues that most people, I would say 9 out of 10 people will go through at any given moment, but also during their lifetime. And that is particularly lower back pain. So we've all had it at some point. Sometimes it's an accident from a motor vehicle accident or a fall, maybe a tackle, playing sport, falling off your bike, etc. But 85% of the time, we wake up and it's just sore, or we bend down to pick up a toy, or start the lawnmower, or getting off the couch, and boom, it gets us. And sometimes it's a little tweak, sometimes it's like we've been shot by a sniper. So I'm going to explain how the diagnosis of, let's say, a disc bulge is really just a symptom, and the real diagnosis is a really long story. So if you or anyone you know are in pain, maybe clients are in pain, then it can be very helpful to know that the client's pain or your pain or someone's pain is likely a really long story, as I'll get into. And people want their pain fixed by yesterday, which is understandable. I've been in pain and I didn't enjoy it, so I get it. At the same time, we need to respect the story of the pain. And typically, if you're healthy enough and vital enough and you're sacred with all your movement patterns, diet, sleeping, hydration, etc., then in theory it can take 1 month to reverse every year of dysfunction. So we all know how to hopefully eat well and hydrate, but a lot of us don't know the mechanism of what's actually going on within our own anatomy, our own mechanics. And so I invite you, if you're not that versed in anatomy, absolutely fine. Use your mind's eye just to picture what this looks like. Don't have to know certain things, but it's very helpful for the trainer, coach, therapist, practitioner to know these things. But I'm sharing with these because I learnt a lot through my old neck injury. And then I had a string of neck patients come through that sort of 6-month-ish period afterwards. And I was able to help them because I knew exactly what I did. Therefore, I knew what they needed to do. And so helped a lot of people, but I had to go through it first. So hopefully I can just explain the theory to you and you don't need to go through it to help someone. But we'll go through the theory anyway. Now, when we're talking about the disc is actually divided into 2 parts. So when I'm talking about the disc, the little shock absorber between the vertebrae and the spine. The 2 parts are the nucleus pulposus and the annulus fibrosus. The nucleus is the central part of the disc. It's composed of about 80% water, like jelly, and it doesn't have any innervation from arteries, nerves, or anything like that. The annulus fibrosus is the outer portion of the disc, and it's shaped like a ring. So annulus in Latin means ring. Ring-shaped object, that's right. And it's circular. The peripheral outer superficial portion of the annulus, not the middle part, think we use jam donut analogy with students. So the jam would be the nucleus pulposus, the donut bit would be the annulus fibrosus. So the outer part is the only innervated part of the disc. It has nerve innervation, blood innervation, and venous sort of innervation. So that's the only sensitive part of the disc. In fact, it's only the last third that's innervated, the outer third. The disc is fed by water from the venous system. So during the day, the disc loses water kind of bit by bit and thins out. At night, the water moves into the disc and then increases the size. So this is why disc issues in particular occur more at night than during the day. And it's the opposite for some joint issues as well. When all the discs fill with water at night, someone can be 1 to 2 centimeters taller in the morning. So proteoglycans attract water to the disc from the venous system, from the lumbar vein. There's tiny little openings in the chondral plate of the vertebra, which is a process called imbibition. So imbibition with motion, the disc space opens and closes with a pressurized pumping. When the disc closes, it pushes fluid out. As it reopens, it sucks fluid back in. So there's a diffusion-like vacuum type effect where the disc takes and quote-unquote drinks in the fluid and nutrients from the blood vessels. The disc changes pressure and is quite sensitive and chemo sensitive. So it's very sensitive to chemicals, and salt is one of them. So salt isn't great for discs. Cytokinins stimulate production of proteolytic enzymes which destroy and absorb herniated parts of the disc if there is a herniation there. But the discs of the lumbar spine have more of a turgor effect. Turgor is something's ability to occupy its own space. So the disc is in tension, and this naturally protects the spine. So the disc is a shock absorber, and all of the discs are connected. So here's where the long story can potentially start. If let's say 15-year-old falls from a tree, bangs against a wall, accident, tackle, whatever it is, that's going to give tension to the disc. Perhaps at kind of L1, which is just below the bottom of the rib cage. And that causes it to become more fibrous and less elastic. Now, let's say fast forward a couple of years, so the person's now 22, 23, 24, and they were to carry something that's a little bit too heavy. That's going to give tension to the disc, perhaps probably a little bit lower down, let's say at L2, 3. Fast forward a lifetime, let's say the person's now 40, 45, and they're trying to build a house and do lots of manual labor. This will also give tension to the disc, but perhaps a little bit lower down. So let's say L3, 4 now. Later in life, if the person were to have bad diet, poor movement strategies, it's going to put more general tension on the discs. Now perhaps at the L4, 5 level. The bad diet is going to decrease circulation and increase fibrosis, so hardening of the disc. The cumulative effect from the connected discs may cause a herniation at, let's say, L4, 5. But this herniated disc does not come back at once because, as I said, it's a long story. Now, the innervation of the disc is a little bit more complex, so bear with me. I remember Jean-Pierre Braal saying that everyone has something going on at L4, 5. The cauda equina is at that level, with the dura surrounding it. Now, there are two parts with nerves, or with the nerve. There's the anterior root, which was originally thought to be just the motor, but also has sensory fibers, meaning the motor means movement, sensory means sensing. And that's connected with the sympathetic nervous system and the posterior root. The posterior root was also thought to be more sensory, but it also has motor fibers, so it's kind of the other way around. And then the spinal ganglion lies posterior to that. Along the spinal column, which isn't technically a column, but that's just what it's called, is the sympathetic nervous system. Now, the recurrent nerve of Luschka, recurrent meaning the nerve that comes back on itself, that's quite important. It supplies sensory to the dura mater, the posterior longitudinal ligament, veins inside the foramen, the venous plexus, the anterior longitudinal ligament, and the arterial system. So a problem with the discs will irritate the recurrent nerve and affect all of the structures innervated by that recurrent nerve. Now, interestingly, I find it interesting, the sympathetic ganglion also has branches to organs and an effect on the vascular system. So if someone has a sciatic problem and the skin is wet, cold or hot, it'd be interesting to see what organ is actually suffering. So when there's sciatica with an accompanying of skin issues, you're sure to have a problem with an organ because of the irritation of that ganglion. The spinal ganglion gives branches to the skin, muscles, and facet. When there is a problem with the disc, there is a problem with the skin, the muscle, and facet. So ideally, you can get them, or we can treat them to have an effect on the disc. So each time you have a problem with the disc, such as when you work too much, you actually lose what's called viscoelasticity. So the disc needs to be elastic in nature, but it becomes tensioned and fibrosed as we go through life. So we lose this viscoelasticity, which reduces the resistance when we do something. Now, if a person is in menopause, for example, working in the garden, lifting weight that's likely too heavy at a weird angle, they can get fissures in the disc due to like a tractioning effect on the nucleus and limited movement of the disc. The disc loses viscoelasticity, which then leads to the bulging and rigidness. So the progression of disc bulges, the disc bulge would push against a strongly innervated posterior longitudinal ligament, deforming it, but not moving through the ligament, so it stays what's called subligamentous. The posterior longitudinal ligament, which runs at the back of the spine, prevents the disc from going straight posterior. However, in time it can deform it, so that's how you can get a posterior disc bulge. With time, and as more of these little fissures form, the nucleus, the jam, moves more posteriorly. The posterior longitudinal ligament always has a weak point where the micro rupture can occur, allowing the disc to move, or clinically called extrude, into the vertebral canal. So over time, the nucleus or the jam moves into this region, creating what's called transligamentous problems. It causes acute sciatic pain that is quite hard to manage. With a sequestration, that's where a piece of the disc is detached from the disc and goes into the spinal canal. This is actually less painful than a more advanced disc bulge, because then the body reacts with what's called a cytokinin, stimulating production of proteolytic enzymes that absorbs and digests the leaked portion of the nucleus. So it starts with bad pain, but then it decreases because of the enzymatic absorption digestion process, even though the herniation itself remains the same. So technically, it's an immune response. And that time can take anywhere from a couple of days to, I've seen up to 6 weeks. Herniations are, I've heard of anterior herniations, but the anterior longitudinal ligament at the front of the spine is really thick. So I feel it was probably misdiagnosed, but herniations that I've seen and heard of in real life are always posterior or posterior lateral. It means backwards or back to the left or back to the right, because the disc is attached to the posterior longitudinal ligament. Now I don't treat to move the disc, but to return the viscoelasticity of the disc. So the therapist should really play a hole of the lumbar spine, not just on L4, L5. If you can decrease the tension, the disc returns to normal. And many physicians who, well, they call themselves disc specialists, but they make a lot of sense, have found sort of 70% of herniated disc patients seen on MRIs and X-rays are asymptomatic, so they don't even know. So that's why a lot of chiros and physios and osteos don't really focus on the herniation themselves. Now, L2 is a really key point. Now, you might have a disc, something going on at L4-5 or L5-S1, but L2 is a really key point, and it's usually always sensitive. And it usually will be more sensitive if there's an issue down below, because from L1 to 5, so in other words, your entire lumbar spine, the sympathetic ganglion is connected with the organs, the skin, and well, a lot of other structures. So there are fibers from the sympathetic trunk from L3, L4, L5, and S1 going to L2. And the disc of L2, the sympathetic fibers are very sensitive, so that's why L2 is sensitive. The sympathetic chain is not the only part that has a sympathetic connection. There are also the recurrent nerve that we spoke about before that comes back to the dura from the spinal ganglion at L2. So the spinous process, skin and muscle of L2 are connected with this recurrent nerve. So that recurrent nerve is called the recurrent nerve of Luxor. So I've had very good results just working at that level. If you're looking for a quick self-treatment or something that you can do quite easily and quick for a disc issue, is actually working with the skin at that level. And you can assess the skin by rubbing your hand up against the spine. The skin should feel really smooth and kind of like elastic. If you feel like your hand almost gets stuck, or it's sweating, or it's cold, or it's hot, and just not quite right, then you've got something happening at the disc. So for me, I always treat the skin first, then the neuromusculature, then the organ, then the disc itself, and then work with the vasculature. But when working on the skin, you can work on both sides. The skin is layered from superficial to deep. You've got the epidermis, the dermis, hypodermis, but when treating the skin, avoid the superficial layers. So you've got to get a little bit of a chunk. And you want to target the traction to what's called the dermal hypodermal junction, which is it's not that deep from how we would perceive it. But this is the most reflexogenic, reactive layer of the skin. The hypodermis is the location, so this is the little junction, location of the hormonal system, the Golgi apparatus. So treating the skin, you want to focus the skin over the top and lateral side of the spinous process. You can traction the skin or just pull it away and just perform and feel where it wants to go. If the skin is too hard and or thick to lift, push the skin in a kind of different direction of the restriction toward the spinous process, with thumbs kind of, using the body to move the patient's body. Either way, the skin becomes more supple with treatment. And we have an effect on the facet, the disc, the dura mater, and the venous plexus. Although, when you bend over and overdo it, then skin might be a little bit more sensitive and kind of thicker within about 2 to 3 hours. Now, the disc is also protected by intrathoracic and abdominal pressures. So the transverse abdominis, or TVA, the thoracolumbar fascia / aponeurosis, the endothoracic fascia, and diaphragm are all connected and are quite important for the maintenance of a good abdominal pressure, which influences disc circulation and disc pressure. So often there's a disc problem due to adhesion or fibrosis of the thoracolumbar fascia, which is attached to the transverse processes. And fibrosis of the fascia and or muscle They doesn't allow good abdominal pressure, and that will cause fibrosis of the disc. The disc has circulation only to the peripheral part, so the disc needs nutrients, vitamins, magnesium, calcium, etc., which is carried by the venous system. The disc needs good pressure to absorb these nutrients. When the disc becomes dry, it has more or less, less or no shock absorption capacity. So the body needs good abdominal pressure for good venous circulation and good disc health. So that's why working core is kind of paramount. Unfortunately, a lot of therapists don't understand what the core is and how it really functions. So treatments to these muscles will be to release the transverse abdominis at its attachments at L2 to L3, L4, and then release the attachment fibrosity. Now, what a lot of people don't also acknowledge, let alone know how to or what to do with it, is the venous system of the disc. Now, we have the superior mesenteric artery branching from the aorta, roughly 2 to 3 fingers below the celiac trunk. The right lumbar vein runs behind the right renal vein, while the left lumbar vein connects to the left renal vein. The left renal vein is quite long. It's about 8 to 9 centimeters long, while the right renal vein is only about 3 centimeters long. The disc has no arterial supply, so it relies on a good venous flow and imbibition, which is that vacuum, to be able to hydrate itself and supply itself with nutrients. This leads to very good viscoelasticity of the disc. So a left kidney problem can lead to a left disc problem. Now, a lot of people have what's called nutcracker syndrome. There's a different nutcracker effect when we're talking sacroiliac stability, but from a vasculature / digestive viewpoint, nutcracker syndrome is where the superior mesenteric artery overlays and can actually squeeze the left renal vein. And this compression is more likely as people kind of age and get more dehydrated and actually become shorter. I found one of the ways to know this is happening is if you lay down and you've got a big kind of pulse in your stomach. So the basivertebral veins come off of the lumbar vein to the vertebrae, and through a small opening in the cartilage plate, it feeds the disc with these nutrients. So both the left genital vein, which is the spermatic or the ovarian veins, and the left lumbar vein flow to the left renal vein. Due to this connection, you'll have congestion of the prostate, uterus, and vagina, creating disc or kidney problems. To say a person has a disc herniation, as you can see, is only really part of the problem. Now, the spinal nerve that is surrounded and protected by the venous plexus. So the spinal nerve is surrounded and protected by the venous plexus. Therefore, congestion of left kidney causes congestion of the venous plexus, which then squeezes the spinal nerve and causes spinal nerve pain such as sciatica. The pain is intermittent and is not consistent because it varies with the degree of venous congestion. It is minimal, comes and goes, and better at times and worse at other times. So when we have a disc problem or sciatica, it can be connected with a left renal vein problem. Lower back pain can also arise from kidney stones, left kidney problems, trauma, prostate problems. Prostate cancer can actually metastasize from the prostate due to the lumbar vein through the left lumbar and renal veins. So when we're talking circulation, each time you stand and when you walk, the load of your body puts pressure on the discs. Pressure decreases when you move your foot forward. So let's say you're walking along. When you move your foot forward, which is the swing through, the pressure increases, when you bear weight or heel strike the ground. Now, when you walk or run, the disc loses and gains water and receives fluid and nutrients via this sucking effect or imbibition. So if you carry a load of about 10 kilos, it creates a tension of up to 100 kilo on the disc, and the disc is compressed and loses water. Unless the disc is dry, it will regain the water in about 5 or 10 minutes. When standing, the axis of the spine is at L2. One of the reasons we have so many problems with L2. Now, when we're sitting, the axis is more L4-5. Bending forward is about 150% more pressure on the disc than when you stand. Side bending combined with rotation is one of the worst things you could do with someone with a disc. With that said, when rehabbing that, we need to find a way to be able to do it, because spinal coupling dictates that side bending rotation happen at the same time. But that's what the check IMS 1, 2 and 3 is all about. Now, piriformis is quite a famous muscle, and a lot of people think they have disc issues or what's called piriformis syndrome. But the sciatic nerve is about 1 finger in width and is normally located underneath piriformis muscle. The piriformis originates from anterior S2 to S4, and sciatic nerve emerges becoming more superficial of the lower border of the piriformis. The sciatic nerve needs to be mobile under the piriformis transversely and longitudinally, with an excursion of several centimeters. So that happens when a person bends forward and side bends. When bending forward, the sciatic nerve moves laterally, side to side, and when returning to an erect posture, it moves medially. With a lumbar disc herniation, you'll have symptoms of sciatica. So tension is maximum in what's called the ischiotrochanteric groove. If a patient comes in with sciatic pain, we have to know where the maximum tension is located within the sciatic nerve. So you need to be able to check it bilaterally and assess where you don't get that traction in the sciatic nerve. So your sciatic nerve must move 4 to 5 centimeters longitudinally when you bend forward. It must move laterally when you bend forward and medially when you straighten back up. I like to work on the surrounding tissues, so like the fascia of the nerves, and not on top of the nerve itself, because you usually get too much of a result, which then you have more of think of a rubber band coming back. So when you're a little bit too hard on the nerve, you can easily create neuralgia. But the main goal in a treatment is to diminish the intraneural pressure. So if you release the extraneural pressure, you have a big effect on the short kind of time that it has intraneural pressure. When there is a sciatic problem, there is a tension on the foramen, and the nerve root can't really glide in that foramen. So just a quick mention of nutcracker syndrome that just came to me, as we mentioned before. It's a compression of the left renal vein by the superior mesenteric artery, and a lot of things can contribute to that, including posture, so kyphosis, lordosis, scoliosis, menopause, kidney infection, genital infection, abdominal pain, lower back pain, particularly on the left. But just remember that the body hates compression. Each time you have a compression, you have a risk for infection, thrombosis, and venous thrombosis, which creates a lot of tension. So we're talking blood flow. A disc without good vascularization will become dry and lose its elasticity. Now, if there's a X-ray, I had a conversation with a mate who's a chiropractor, and he thinks this is false. And it's weird because I've shown it to a few osteos and a few chiros, and all the osteos agree, but the chiros disagree. So let's see what you think. If you had an X-ray of the spine, and someone you see that there's no space between the vertebrae for the disc, that's false. This is according to osteo. The disc is in a concavity that develops in the upper and lower body of the vertebrae on each side of the disc. The disc appears to be thinner on X-ray when really it's just hidden inside the bone. Now, I only bring that up because many people get an X-ray or an MRI or whatever, and then they look at that, the person who either took it or is examining it, doctor, chiro, etc., they're going to look at it and say that's what that is. Boom, done. That's gospel. But this is how it can be a little bit tricky for some people, because just as that example, both require two different approaches. So it's important to not invest just in one thing, because I know many people with a disc bulge, as an example, won't just have a disc bulge going on. That's the diagnosis medically, but they've also got, say, disc bulge at L4-5, they might have degeneration at L5-S1, stenosis at L3-4. So there's multiple things, and each require a fairly significantly different approach to each condition. But then they only have one diagnosis of a disc bulge, so they go through the protocols of a disc bulge and they get worse because it irritates the other things. Sometimes when we have, multiple things, one day the disc bulge could be talking to you and it'll hurt when you move that way. The next day the irritated facet joint is going to talk to you and it's going to allow you to move another way but hurt a way that normally doesn't. So multiple things can talk to you at multiple times. And even arguably underdiagnosed as well would be the effect of the end plate. Now, I know T12 is a relatively weak vertebra that can fracture, especially during menopause. In the vertebral chondral end plate, there are little openings, kind of like a little espresso maker. And these openings permit the blood circulation to feed the discs. During the night, when we're in deep sleep, there is a dehydration-hydration cycle moving the water into the disc. The disc becomes larger, creating more tension when there is a herniation. Now a test you could probably do is, the test for the vertebral end plate is rotation. So you can take one spinous process between the fingers and the thumb and just gently rotate one hand over the other. I always start at L1-2. But when you're testing or when you're doing a rotation, if you feel an immediate resistance, that's usually a facet restriction or blockage. If you feel the resistance coming a little bit later, it's likely the cartilage or the disc itself. Now, just to reiterate the importance of the venous system, any disc issue will affect venous flow. Now, different disc sizes are in, the lumbar discs are about, can't remember now, I think it's 11 mil. Lumbar discs are about 11 millimeters thick. Thoracic are about 5 to 7 millimeters thick. And then the neck discs, cervical disc of the neck, they're about 3 millimeters thick. But any herniation or trauma to the neck, thorax, or lower back creates venous congestion. And ideally, the therapeutic exercises will help pump that through. But it is very important for us to decongest the venous system in order to have an effect on the disc imbibition, so that pressure sucking And one of the key areas as well is the external jugular vein, which carries venous blood from the head, and from the vertebral vein, which has different branches from the cervical vertebra. The occipital vein and the venous plexus around the foramen magnum are also quite important. So this is why forward head posture can be such a big deal. With venous congestion, you will have inflammation around the nerve root and neuralgia. The veins and venous plexus that come from the head and neck are draining into the subclavian and brachiocephalic veins. The veins carry a negative pressure from the thorax to lighten and protect the brain. And they have a kind of like that sucking effect on all the venous system of all the vertebra. A fixation in the thorax or that kyphotic bent forward posture won't allow this effect. So for any neuralgia or arthrosis, it's really important to correct posture and get the venous flow going. But a real key point to release is what's called the venous angle, where the internal and external jugular veins meet the subclavian and brachiocephalic vein just behind the clavicle. Now, interestingly, when you hold your breath, you get a dilation of the vein. The brain needs negative pressure to lighten. Inhalation increases the negative pressure, lightens the cranial area, and allows better drainage of the venous system. Also, when you breathe in, blood drains. As you breathe out, it fills back up again. So going back to the importance of correct breathing mechanics. So as you can see, we are walking around in a pretty complex machine that nature was kind enough to lend us. And hopefully, if you can get something out of today, it's that there's no such thing as isolation in the body. There's no such thing as a disc bulge. It's a body problem, or body bulge. There's no such thing as lower back pain. It's a body pain. You don't have a joint pain, you got a body. You don't have a joint problem, you got a body problem. And try not to go too technical, but I think I lost that little dialogue with myself. But I hope you found that interesting somewhat. Stay tuned next time. We have a very exciting guest coming up next week. And if you like these episodes, please let us know. We would love a warm review and a 5-star rating. And if you feel this episode could help someone you know or someone you like, even yourself, then job's done. So thanks for joining me. See you all next time. Bye-bye.